Well, hello, everyone. It's nice to be back with you all for our ongoing ASN Policy podcast. We're going to do something a little bit different today. It's David White here. Todd Ibrahim is not going to be joining us today, but we're going to be joined by two very special guests, and we're going to really have a very exciting conversation about a really exciting topic, which is, of course, transplantation and a lot of things that are happening there. But first and foremost, I just want to introduce our two guests. Our first guest is Dr. Michelle Josephson, who is also president of the American Society of Nephrology, and she's joined by Rachel Meyer, who is the Strategic Policy Advisor to the Executive Vice President. Welcome to you both.
David, I really appreciate the invitation to be able to be here today and to get a chance to talk about this subject. And I'm very excited to be here with Rachel talking about this really terrific topic.
Thanks so much, David, and thanks so much, Michelle. I, too, am thrilled to be here today talking about the many exciting things going on in transplant that we at ASN are focusing on a tremendous amount in 2023.
Well, great. Let's jump right into it because there's a lot happening. And we're going to talk about a lot of the things that are happening. Some of them are already underway, and some of them I know the ASN is working on. Michelle, I think, when we were talking before, you really seemed to be focused on some really big picture issues that you think nephrologists, our listeners here really need to think about. And I just wanted to know if you wanted to expand a little bit about kind of what you want them to be thinking about as we go through a year that's going to be very focused on transplant and for many years to come.
I think that's a great way to get into this topic. I just want us to all step back for a moment because we are going to get, I think, into the weeds about some of the policy issues. If you sort of step back and think about what these policies may give patients the opportunity for, it's really transplant access. And one of the areas that ASN and a number of us in transplant are so passionate about is the idea of maximizing patient access to transplant. And I think that it's some of the topics we're going to be touching on really open up the door to improve that access. As well, I think it's time for us to sort of think and talk a little bit more about the role of the nephrologist and the transplant nephrologist. And one of the issues that has been true over the ages is there's always been a little bit of a silo or maybe a little bit of a division between, maybe division's the wrong word, but maybe a little bit of a separation between general nephrologists and transplant nephrologists. And to be able to help our patients most, we really have to work across silos and work together and work within the transplant space collaboratively. And I think some of what's going on will help us to do that and to be able to make the patient's journey more seamless than it has been.
That does seem to be something that ASN is always talking about, is making it seamless and trying to keep transitions from being hazardous to patients with their ability to do that.
Thanks, David. I think another thing that ASN has long focused on that the work in transplant in particular embodies is ASN's focus on equity. As Michelle said, making sure that we're maximizing patients' access to transplant, but at the same time making sure that that access is equitable, because we know that transplantation at present, although we have made great strides, it is not equitably accessible across many different, fault lines, socioeconomic, geographic, racial and ethnic, gender. So that's a huge component as we think about ASN's work in transplant and policy and beyond.
I'm glad you brought that up. And I would also add to that, another area that some of these policies speak to and may help is the issue of transparency, which is another area that ASN is really dedicated to enabling the patient and others involved. And I know we'll talk more about this a little bit, but transparency to know more about what the process is and where things are going.
I'm going to take you into some of those spots right there because I know you guys have a lot to share. And Rachel, I think we were talking a little bit about the very exciting announcements from the Health Resources and Services Administration that we all refer to as HRSA. And just you want to just give our listeners a little quick update?
I would love to. So as David said, we recently welcomed big news from HRSA, the agency recently unveiled what they have termed their Organ Procurement and Transplantation Network, or as we call it, OPTN, Modernization Initiative. And this is particularly exciting to us at ASN because this is really years of ASN advocacy along the themes that we've been talking about: transparency, accountability, maximizing patient access, coming to fruition through policymaking. I would say, big picture, some of the key things that this announcement aims to do through policy changes that are going to be rolled out over the coming months and years are around really increasing data transparency and data sharing so that patients, their families, to Michelle's earlier point, their general nephrologists who are trying to help them navigate the transplant system, as well as the research community, have more insight into really what's happening at every stage throughout the transplant process.
Michelle, what Rachel is talking about, I know she's got more to say about that, but I think you have also said in the past that you consider that system a bit monopolistic. Is that correct? Would you say that's the case?
Yes. No, I would say that is the case. There's only been one contractor for the history of OPTN. Whether or not that contractor is the best contractor is, a point of maybe, discussion or a point of perhaps debate among people. But it, without some ability for others to get in there and show alternatives, we may not have the most optimal system that we could.
That is precisely one of the big, if not the biggest change that this OPTN modernization initiative will begin to allow, which is changing the structure of that OPTN contract so that multiple bidders with expertise in the many different areas, whether that be policymaking or information technology or others, can come in and share their proposals or ideas of how they may go about providing patients what we hope are best-in-class services in each of these important functions. Certainly we at ASN have no opinion on who the best contractor would be. We just want the contracting process to make sure that it's conducted in a way that we all know and have the confidence that patients are being served by the best possible contracting agent.
Rachel, you brought up transparency. You brought up the contract. I think there's some other points there that you were bringing up as well, about to bring up as well, right?
Indeed. So one of the other areas that is a particular focus of the OPTN modernization initiative that we at ASN have been calling for years is a distinct focus on modernizing and improving the information technology system. So kind of the underlying tech that supports and makes our entire nation's transplant system work. And there's been a lot of attention and many stakeholders across the government as well as outside, such as the NASM report, have pointed to the need to really draw on 21st century technology to better serve patients and better serve the transplant professionals that are supporting them in the system. So we're very excited about HRSA's focus on making sure that all of this underlying technology is industry-leading standards in the future.
Rachel, you brought up a term, NASM report. You want to make sure that our listeners know, caught that. Can you tell them exactly what that was?
Yeah, great point. We tend to speak in acronyms around here. So the NASM report stands for the National Academies of Science, Engineering, and Medicine. And last summer, the National Academies released a more than 200-page report looking at a number of ways to improve and optimize and continue to make strides in our system of deceased donation in this country. And germane to this conversation, one of the areas that NASM really focused on was modernizing information technology, as well as some of the other changes that we talked about that are part and parcel of this big OPTN modernization initiative. So I think what you're really seeing here is years of advocacy and research from ASN, from the National Academies, from many other stakeholder organizations, including patient advocates like the National Kidney Foundation and others, bearing fruit in the form of this big HRSA announcement.
Well, that's exactly what struck me, was that this is really the culmination of many years of work, and it is going to continue for a while. This is going to be a very big lift. I wanted to ask Michelle a question because, Michelle, you've talked about the black box that occurs around the transplant, and the lack of transparency about that. I was wondering if you could tell our listeners a little bit more about how you see that as a transplant nephrologist.
Yeah, so when we think about the patients who go to be evaluated for transplant, there are many aspects to it and sides to it, and often no one has any idea sort of what the process entails, and as the patient is in the process, where they are along the journey of evaluation, of kidney offers. And so if we think about a box with 6 sides with a patient in the middle of it or in the center of it, we can think that the sides might include dialysis staff who may be encouraging the patient to get into the system and then not knowing where the patient is in the middle of this box. We could think of the general nephrologist similarly, who may be talking to their patient about getting a transplant, and again, doesn't really have a good sense once they're over there in going over to the transplant center or under evaluation or getting testing where the patient is. Think about hospital management that's maybe involved in deciding what's going on within their system locally at their transplant center. You think about the regulators in government who have metrics or who have expectations or who are monitoring different things, who may know certain aspects of the process and from the outside, but certainly don't know the whole box and don't know what's going on in the middle. You can think about transplant surgeons who certainly, have a key role in the process, but again, don't always know everything that's going on, but maybe have one side of it. And transplant nephrologists, similarly, who have another side, a different side from the general nephrologist, but also are involved in the process. And we all together, put together, make up this box that contains this patient, and no one really knows exactly their side of it. And the patient is in the middle of it, but the patient doesn't necessarily know where in the middle of it they are, and each side of it doesn't know exactly where in the system the patient is. And so there really is a lack of transparency. We have to break down that box or demystify the box by really providing, I would say, more information to everyone involved, everyone on who has a side or is a stakeholder, so that ultimately we can really work best towards serving the patient. Everyone has their side or their agenda, but at the end of the day, it's really the patient whose agenda really matters. I have had, patients come to me and say, each program is their own little fiefdom, and we don't, and they sort of feel like they are in a different process each time. There's no really centralized process or real clear communication to the patient about everything that's going on, pulling it together, and that's because in a way we each only see a piece of it.
Rachel, you and Michelle have been working on this a lot, demystifying the box, right?
Absolutely. As ASN has put together kind of our cross-cutting transplant policy agenda for the year, transparency has really been at the heart of it. As Michelle alluded to, we believe that patients really deserve a coordinated kidney health ecosystem-wide approach that allows all stakeholders to work towards maximizing patients' access to transplant. And I don't think that's something that the system at present really does, in large part because, as Michelle said, people don't necessarily, all the stakeholders on each side of the box don't necessarily have the information at their fingertips to achieve that goal. So some of the concrete examples of policy changes that ASN is calling for in order to help achieve that transparency include things like providing patients and their general nephrologists with asynchronous updates about organ offers that were made to a particular patient to really help them understand the decisions that are being made on their behalf and in support of their best interests. And our hope is that by providing those updates about organ offers, say every 3 months or every 6 months, it really will be able to foster more patient engagement in those decisions and ensure that those decisions are made on an individualized basis that reflects each person's own care goals for kidney transplant and kidney transplant versus dialysis. That's one example.
Yeah, I'll offer another one also, which is, and it really gets and ties in the issue of kidneys that may be offered out of sequence. So when that's done, a patient may think they're in a certain place, but if there's no knowledge that kidneys, or it's not that there's an exact place on the list, but just sort of where they are in their journey in the big picture. When this happens, if a kidney is offered out of sequence, it may bypass a patient and their program, or even their transplant nephrologist or transplant surgeon may not even be aware that kidneys are being offered to other programs when they thought they were perhaps the next up for a kidney or would be very close to getting a kidney transplant.
Michelle, why does that happen?
So that's an interesting issue, and that I think one might say, every system has unintended consequences, and there's certainly unintended consequences in the transplant system. And one of the issues is to try to have organ procurement organizations place kidneys, and so one could imagine that organ procurement organizations are under a tremendous amount of pressure to place the kidneys, not to have discards. And so in order to make that happen, they are working as they see most effectively to place these kidneys. And so they will often decide, or just based on experience, know that certain programs are more willing to take kidneys, and so it's easier to place those kidneys at certain programs, and so they may preferentially send those programs to, program X, even though a patient at program Y had, if that had not been the case, if it was just done sort of based on waiting time for the patient, maybe program Y would have gotten that kidney. But the organ procurement organization is concerned that program Y is going to turn down that kidney. And so they just go to the programs where they feel that they could have success. Totally understandable. Makes a lot of sense. The problem is for the patient that it doesn't serve the patient best. And so I think what we've been saying here is we are, throughout this podcast, is that we're looking to make changes that serves the patient best. Doesn't serve the program best, doesn't serve the OPO best, but serves the patient best.
And that does bring us to the other issue that you both have brought up with me as we were preparing for this broadcast, which is where we are in terms of, I know that you guys can tell me you don't really like this term, so I'll let you phrase it a different way, but what is commonly referred to as organ discards. So how about you tell our listeners a little bit about what's been happening in the last couple of years there?
Yeah, so I'm going to let Rachel tell you the better word for this, because I think we all understand what that means, and it is not a wonderful word, but we all understand what that means when kidneys are not used. If you look over time, there is an increase in the number of organ discards. And that's very disheartening when you think about the fact that we have over 95,000 people on a wait list who would benefit from a kidney transplant. And so to think that there are kidneys that aren't being used is very distressing. Now, I also want to make clear that, and some listeners are probably thinking, well, not every kidney should be used. And you're 100% right. Not every single kidney should be used. And for some some kidney transplants would be worse than dialysis. But many, and perhaps arguably most kidney transplants would be better than dialysis. so we really want to increase use of those kidneys. And so there is a lot of pressure on OPOs to place kidneys, 100% understandable. Now you may say, why are organs discarded? And there are probably many, many reasons, or not used. I'll say, why are organs not used? There's probably many, many reasons why they aren't used. And if you look within a specific program, per se, why they might not use an organ, one issue is, does the program have the capacity to use all of the available organs that they may be offered? Do they have the staffing to be able to do that? Do they have the staffing in terms of the transplant program or in terms of the hospital itself? And I think as we start to think about trying to use as many organs as possible, we have to be ready to use them, which means that we have to have the staff at the transplant programs ready to expand, ready to use them. And that isn't just about the transplant programs. It's also about the hospital administration being willing and ready to invest in transplant at their institution so that the programs can grow and use these organs. And especially if the organs are not pristine, it may mean that there needs to be more staffing availability and more hospital availability to take care of patients who have delayed graft function, who may need extra resources to make the kidney transplant a success. Rachel, I'm sure you have other thoughts or comments on this too.
You know, this is such an incredibly complex issue, the issue of organ non-use or organ discard, whichever, term you prefer. And every point you've made is an important one. And two other facets to this complex issue are, this is one of the reasons that we at ASN are so interested in changing policy to eliminate the use of one-year outcomes metrics that programs are evaluated on by the MPSC. We'd like those to go away or at least recede into the background relative to other metrics that are a little bit more long-term or patient-centered, to allow programs to be a little bit less risk-averse in their decision-making. And should they have patients who say, you know what, I really would like you to accept perhaps a less than perfect kidney on my behalf, that would be my choice and my preference versus dialysis. And that, of course, brings us back to the second point, which I've touched on earlier, which is identifying ways to really bring the patient voice and that patient decision-making into organ offer acceptance practices at a given program.
Okay. Rachel, you mentioned an MPSC. Could you tell us what that stands for?
Yeah, so the OPTN, the Organ Procurement and Transplantation Network, has a committee called the Membership and Professional Standards Committee that really monitors programs to make sure that they're operating in compliance with HRSA and OPTN rules that aim to protect patient safety and ensure that programs are operating as they should. But as Michelle mentioned earlier, in health policy in general, and I think in transplant policy in particular, we do see a lot of unintended consequences that emanate from very well-intentioned policies. And I think the use of one-year outcomes metrics in transplant program evaluation is perhaps one of the best examples of an unintended consequence. And in fact, in recognition of the fact that one-year outcomes metrics were sort of unintentionally perhaps creating barriers that did not maximize patients' access to transplant, the Centers for Medicare and Medicaid Services actually retired the use of one-year outcomes metrics with the hope that it would permit some programs to be less risk-averse. Unfortunately, we haven't seen, I think, kind of the changes in practice that we had all hoped would emanate from that change at CMS. And we believe that's in part because of their continued use of one-year outcomes metrics at the OPTN level through the MPSC. So that is one of ASN's top policy goals, is to really identify other metrics and replace the one-year outcomes metrics with ones that are going to be in line with our goal of maximizing patients' access to transplantation.
Rachel, it strikes me that when you're talking about the conflicting expectations of OPTN and CMS, that this is again another example of how when things are siloed, it can lead to problems as opposed to a unified approach.
Well, as we get nearing the end of this podcast, I want to make sure you guys have a chance to talk about something that I've heard you talk about a great deal, which is these are a lot of policy changes. However, you need more information because you need to find out who's making the wait list and who's not making the wait list. And that information, I think you've talked about a lot, Rachel, and so you, Michelle. So I want to make sure you guys had a chance to address that.
That's right, David. I think up to this point in the podcast, we've really only talked about policy changes that would affect patients who are already on the wait list. But we need a whole lot more information about who isn't making the wait list. People who, the approximately 90,000 Americans who are currently on that list really constitute the tip of the iceberg. There are many more patients, among the 400,000 or so others who are on dialysis that are sort of proverbially beneath the water, who would likely benefit from a kidney transplant and who we probably would actually want to see waitlisted in the future. But the first step toward making policy changes that would enable more patients to get on the wait list is to begin collecting information about transplant referral and evaluation practices so that we can really better understand what is or what isn't happening with those patients who aren't waitlisted, so that we can understand any barriers and then develop policies that help us overcome or eliminate inequities in access to getting on that wait list. I'd like to give a shout out to Rachel Passer, who has been informing a lot of ASN's thinking and work on this pre-waitlisting initiative. She deserves a tremendous amount of credit for surfacing this as such an important element in our transplant system.
And Dr. Patzer is an ASN member who serves on the Policy and Advocacy Committee, if I'm not mistaken. So Todd always asks me for the last word. What's your last word that you want to leave people thinking about? Let's go to you first, Rachel, and then we'll have Michelle, as our president, wrap it up.
I think our listeners have heard us talk a lot this morning about the challenges of a siloed system and kind of conflicting incentives. My final word would be, we need a central office of kidney health and transplant policy at HHS to help make sure the entire kidney health ecosystem is working in synergistic coordination.
And I would say that in addition to that, we also need to give our patients the tools so that they can work best within this ecosystem. And one thing I would like to advocate for is the ability for patients to get information so that they know what's the best program for them, and that they are not dependent on others to make decisions for them about where to get their transplant, what is the best fit for them, where they should go to be evaluated, and even before they're advised or encouraged to get a transplant, so that they have enough information that they are asking, shouldn't I be evaluated to get a kidney transplant? So I think we need to give them enough tools so that they can be partners as we care for them and help them through this journey.
Well, thank you both.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.